the English version of this webinar, please stay put.
Sí, buenas tardes. Las personas que deseen escuchar la versión en español, favor de elegir el idioma de español oprimiendo el botón en forma de círculo donde dice ahí español en la parte inferior de la pantalla. Gracias.
Again, welcome and good afternoon to all of our live attendees today. We are thrilled you're here to engage in our exciting webinar titled School-Based Integrated Care, Confidential and Accessible Behavioral Health for Young People. I'm Julie Chronister. I'm one of the hosts of our webinar today. And first things first, a brief audio description of myself. I'm a white cisgender female, pronouns she, her. I have light brown shoulder length hair, gray and black rimmed glasses, and I'm wearing a black V-neck top, and my background is blurry. I'd also like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We're committed to ensuring this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. I'm a faculty member in the Department of Counseling, the Clinical Mental Health Counseling Program here at San Francisco State, and the primary investigator of this project. I'm working alongside my project co-investigators, Dr. Tiffany O'Shaughnessy and Dr. Molly Streer, who are also faculty in the counseling program. I'd also like to thank our graduate assistant, Ro Cordova, who was working hard to stay on top of the technical issues, chat boxes, and all that other good stuff today. Thank you, Ro. This is our 7th of 10 webinars sponsored by our Equity and Justice Focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources, and Service Administration as part of an award totaling $1.9 million. A couple things before we begin. If you are one of our HRSA stipend recipients, or you are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Reminder that this is a live recorded Zoom webinar. Therefore, the audience is not visible and the audience cannot turn on their video or audio. The chat function is available today for questions, comments, sharing resources, and posting fun emojis. If we cannot get to all the questions, please contact the presenters directly and we will provide that information at the end. Also, please note that this PowerPoint and this recorded webinar will be posted on our website in approximately a week. So it's great pleasure today that I introduce today's presenters, Michelle Maddox, Sarah Taylor, and Meg Yardley. Michelle, Sarah, and Meg are all licensed clinical social workers and behavioral health clinicians at La Clinica School-Based Health Center. Our 3 presenters bring over 30 years of experience working at the intersections of education and healthcare with youth through trauma-informed and justice-oriented school-based integrated behavioral health care. Our presenters bring justice-oriented clinical policy and structural change expertise, and we are thrilled to have them present today. With that said, I will now hand it over to Michelle, Sarah, and Meg.
Hi, everyone. Guess we didn't decide who was going to start. My name is Michelle Maddox, and I am one of the integrated behavioral health clinicians at our school-based sites. I'm at Fremont Tiger Clinic in Oakland. I use she, her pronouns, and I am a white woman. For a visual description, I have shoulder length blonde hair. I have a gray sweater on and a tan wall behind me. And I will pass it to you, Sarah.
Yeah, thank you. Hi, everyone. It's good to be here. My name is Sarah Taylor. I am a mental health clinician in one of our school-based health centers in Havens Court neighborhood of Oakland, California at CCPA, which is a 6th through 12th grade Oakland Unified School District school. and I bring about 10 years of experience to this work. I'm a white queer woman. I use she, her, and a visual description of me is that I have shoulder length brown hair. I'm wearing a dark green sweater, and I have a tan wall with a mountain tapestry behind me.
Hey everyone, my name is Meg Yardley. I work at our clinic at Oakland Tech High School in North Oakland, which also serves Oakland International High School. My pronouns are she, her, identify as a queer white woman and a parent. And for visual description, I have short hair. What is this haircut called? I don't know. Glasses and an orange blouse. And you can see a little bit of my office with a poster behind me that says survive with some birds and sunshine. And I think as part of our introductions, we were also going to maybe each just share something funny that we've heard from a student recently. So one of the things I love about school-based work and working with teenagers is that there's always something funny happening. So mine is that I have a group of seniors that I'm working with, and I had brought some lavender eye pillows to give out. So usually young people really love these eye pillows. They're very relaxing. So I told the group, everybody, I know it's a time in the year when everybody's really stressed and you might need something to help you relax. So I brought these to give out to you. And as I reached down to get them out of the bag, one of my students said, condoms. So that was my funny story of the week.
Do you want to share a funny story, Sarah?
I just got off of a plane and I don't have a funny story prepared, so go for it.
Yeah, my funny story is I had a student, a freshman male, come in and he said, "You're going to be so proud of me." And I was so curious to see what he was going to say. And he said, "I got myself a girlfriend." It was just like, was so excited to share his news. Yeah, so we're going to share some more examples and we'll get into the content. But before we get started, we also wanted to acknowledge that we are 3 white women and we are working in schools with many non-white students. And it's really important to each of us that we are aware of and working with our positionalities and identities in our work, and that we're acknowledging the inherent power dynamics that exist. We also recognize that there are many systemic limitations in both our profession as social workers and our organization that impact the recruitment and hiring of a more diverse workforce. And as social workers, it's really important to us, and we are committed to both an awareness of and an active engagement in dismantling these systems, both in our clinical work and beyond. So that will come up throughout our presentation today as well. And we will go ahead and get started.
Michelle, we had a request to slow down a little bit for the captioning and translation.
Thank you. So why are we here and what are we going to do today? We have a few things we're going to focus on. The first is why school-based care. So we'll talk some about the benefits and challenges of integrated behavioral health, specifically in school-based settings. And then we will talk about how students come to us, so the pathways to care through medical and schools. And then we'll also talk about what works. So we'll give some examples, like I said, case studies. We'll also do a couple things together, and then we'll go through some of our favorite youth-friendly therapeutic modalities in the brief care setting that we are working in. And we will pause a couple times and ask for questions throughout the presentation. And then at the end, we'll also have a more extensive time for questions. Please feel free to put your questions in the chat during our presentation, but if we miss them, feel free to put them in again when we get to the Q&A spots, if we happen to not see them.
All right, so before we jump into content, we wanted to take a moment to just have a moment of mindfulness. This is something that we do often in our work with young people. And actually, I guess my funny story this week should have been that I have been working with a senior who has been managing anxiety for some time and had not really been interested in mindfulness prior to more recently. And this last week, he decided that he was going to give it a try. And so we did this exact script together. And afterwards, he came out of it and he was like, "Oh my gosh, it works. I feel so much better. I feel like I actually paid attention to my body. And I was like, yeah, this is what I've been trying to get you to do for like 2 years. But it was just this very funny, very sweet moment of, right, sometimes folks come to this in their own time, and we were able to connect too. I said, yeah, it feels a little awkward at first. I felt awkward when I first tried it. So anyways, yeah, we're going to take a moment. And if anyone who does have their camera on wants to turn it off, feel free. And we'll get going here. I'm going to invite you to just go ahead and take a deep breath, noticing your surroundings. And then just go ahead and start to notice if you can feel your hair touching your head. If you can feel your belly rising and falling as you breathe. Can you feel the space between your eyes? Can you feel the distance between your ears? Can you feel your breath touching the back of your throat when you inhale? Can you notice your arms touching your body? Can you feel the bottoms of your feet? Can you hear any sounds in the room? Can you feel the air against your cheek? Can you feel the muscles in the back of your neck? Can you feel all the fingers in one hand or the toes in one foot? Can you feel the temperature in the air around you? Can you notice a part of you that is relaxed? Can you notice any tightness in your jaw? Can you taste anything right now? Can you feel the seat or floor under you? Can you see the darkness behind your eyelids? Can you hear your breath? Can you feel any part of you that is warm? Can you notice the ribs around your lungs? Can you allow yourself to feel sleepy, lazy? Allow yourself not to focus on the things around you. Can you feel your face relaxing? Can you notice your body in its strength and resilience? And when you're ready, you can go ahead and bring your attention back to the space that you're in. Go ahead and move your body however feels comfortable to you, however you've been wanting to. And thank you all for being here with us. I'm going to pass it over.
Thank you, Sarah. So we want to go ahead and try to remember what it was like to be a teen or a young person before we dive in. So I'm going to change screens in a second, but if you want to, you can get the code with your phone camera beforehand. Otherwise, you can go to menti.com and put the number in, or we will also put the link in the chat. So I'm going to give you just a few more seconds to take a picture or open your phone camera on the QR code if that's the way you want to do it. And then we are going to go to the Mentimeter. So the first question is, what did you like to do for fun as a teenager? So go ahead and put in your answers. Sarah and Meg, you're seeing the Mentimeter thing, right? Great, okay. So hang out with friends, go to movies, shop, skateboard, call on the phone. They don't do that as much these days. Roller derby, watch music videos, play sports, skating rink, read, skateboard, listen to music, go to the movies, go to punk shows. So we hope as you think of these things you like to do, you can kind of remember what it felt like to be a teenager. What were the things that brought you joy? How did you spend time with your people? And when you're done with that, we will go ahead to the next question, which is, what feelings come to mind when you think about how you felt entering a doctor's office or a therapist's office or any sort of kind of healthcare setting when you were a teenager? Anxious, nervous, scary, unsettling, shy, defensive, scared, cold, uneasy, support. I'm glad someone had some positive experiences. Okay. Weird, frustrated, embarrassment. Didn't go to the doctor, didn't have access. That's an important part of our presentation as well. Disempowered, it's a really good one and really important. Curious, strange. So yeah, a lot of feelings come up for teenagers and young people in these settings. And so our hope today is to kind of like come in with these rememberings of what it was like to be a teenager as we talk about how we try to make these services accessible and empowering for students. So we will go ahead and go out of this. Let's see. And I will pass it on.
Okay, so we wanted to just open here with a case example, just to give an example of some of the ways that school-based integrated behavioral healthcare can look. So this is a student that we will call Edwin, who was an 18-year-old who had immigrated to this country a little less than a year before I met him. He's someone who really likes soccer, he likes running, and he likes action movies. And at the time that I met him, he was working more or less a full-time job in a restaurant, as well as attending school full-time. So he had come to our clinic for medical care because he had a history of chronic back pain due to a prior injury. But because, as we're going to talk about in a moment, our medical practitioners do behavioral health screening, he had a positive trauma screen and also a positive depression screen. So meaning that he showed both possible symptoms of trauma and also moderate to severe symptoms of depression. And so our medical provider referred him to me, and he shared with me about feeling sad a lot of the time, about really missing his home country, struggling a lot with sleep. That was a major issue. That was also affected by some of the chronic back pain that he was having. And he also shared about a trauma history where he had been physically assaulted by gang members in his home country. And since that time, although to some extent he felt better being away from the country, you know, we are still living in a city in Oakland, and he still found himself experiencing flashbacks and intrusive memories and feeling a lot of hypervigilance as he went about his daily life in the streets and worrying a lot for his own safety and for others. So some of the things that were really helpful based on what Edwin shared with me at the end of our working together, we started out by just doing some psychoeducation and really just talking about trauma in the body, about what the body's reactions to trauma are like, about fight, flight, and freeze. Edwin expressed a lot of relief in having an understanding of what he was feeling and recognizing that this wasn't something that was wrong with him, but that these were actually reactions to things that had happened to him, that he had been through. He participated in a 10-week trauma group that we were doing at his school that I co-led together with a case manager from the school. That was all the students in it were newcomer immigrant youth. And in that group, he was fairly quiet and didn't tend to share a lot about himself. But when I would talk with him individually, he shared with me that it really helped for him to hear what other people had to say, to hear other people talking about their stories, and to hear that, you know, he wasn't the only one going through some of these experiences. In that group, we did a lot of focus on teaching skills to deal with trauma symptoms. And Edwin, along with other youth in the group, expressed those were really his favorite parts, and the parts he found most helpful were learning mindfulness and relaxation tools. Also the lavender eye pillows from before were a big hit. But really that learning some of those practices that they could take and use on their own were things that he found very helpful. And then following the group, when the group was over, I continued to meet with him for individual therapy. And at that time, following the group, the symptoms of trauma were much better. He wasn't experiencing anywhere near as much hypervigilance or intrusive thoughts. He was still definitely struggling with some depression, and that's what we focused on more in individual sessions. And also I worked together with the medical provider, so this is part of the integrated behavioral health, to address the chronic pain, which got a little worse around that time because of his job conditions. So we were able to collaborate to support him. The medical provider taught him some exercises to help with the back pain. And the medical provider also wrote him a letter for his work so that they could give him different job responsibilities that would make the back pain better or that wouldn't exacerbate it. And then he and I were able to work together on relaxation, which was helpful for dealing with the pain, since chronic pain often causes tension, which then usually makes the pain worse. And also what we usually call behavioral activation. So just helping him to reconnect with behaviors that helped, which in his case was running, which is something that he loved to do. And that when he did it, made a difference for the pain in his back. And when the chronic pain improved and got to a better place, that also made a really big difference for his mood, and the symptoms of depression lifted quite a bit. And he graduated, I think, 2 years ago now. So it was really great to see him graduate from high school.
Thanks, Meg. We wanted to go ahead and pause now and see if there's any questions about this case, about the work that Meg did, or anything that's come up so far. And like I said, we'll have more time for questions later, but we did want to give you all a chance now. If there are any questions, please feel free to put them in the chat. Cool, no questions yet. Keep thinking of them and we can come to them later if you have others. So we will go ahead to them.
All right, so in school-based health centers, and particularly in integrated behavioral health within the health center, some of the benefits that we see is that there's really low barrier to care with really flexible schedules. What I'll see a lot is even in an integrated behavioral health care setting in community-based, which has lowered barriers quite a bit, that young people often are still having a harder time maintaining their mental health care, keeping track of their own appointments, being able to reschedule them. In clinics where there's higher volume of folks, sometimes, you know, a young person might miss one appointment and then have to wait 2 or 3 weeks for another appointment. And generally, we can be a little bit more flexible in school-based. There's increased opportunity for collaboration with the young person who's there, and more accessible to us. Also, if I have a question or I think, oh, I can schedule this appointment with a parent as well, I can pull a student the same day and talk to them about that. more collaboration with the school itself, and of course collaboration with our medical providers. The school health centers can also enhance the school climate and allows for more effective school advocacy. A lot of times we're spending a lot of our time outside of the clinic, really building relationships with schools, building trust with schools and administrators, and engaging in culture and climate work to support the school in becoming more healing-centered places. We're integrated into the youth community, which speaks of the first one, just a lower barrier to care when they're seeing us around a lot and the health centers are situated on campus. There's a reduced stigma. People come in and out of the health center all day long, and so accessing mental health care at the school-based health center seems to be really low stigma, and a lot of times people will refer their friends as well. Because it's a school-based setting and all of us are specialized in providing care to young people, do you think that youth have an increased agency and choice in services that they're receiving and shaping them? There's a reduction in hospitalizations because there's access to care hopefully before the point of crisis. Oftentimes we're seeing people who are at a really early stage of their stress level. We're able to see people who don't have any diagnosis at all the way up to folks with more severe impact. And then increasing access to services under minor consent, which we'll get into. But there's just more confidentiality, and students are more able to get services privately without needing a caregiver necessarily present.
Yeah, so along with the benefits, obviously there are some challenges in school-based health, integrated healthcare, and some of them are kind of like the opposite side of the benefit. So as Sarah said, it's awesome, we can just pull kids out of class and it's really flexible and we can make it work, but sometimes it's challenging for students to come to therapy in the middle of their school day. We're not talking about light stuff necessarily, so coming in and opening up and then going right back to class and having to re-engage can be challenging for some students. And same with the minor consent. So in California, over 12 can consent for their own mental health care and a couple other types of health care. So we often don't have parent involvement, which, like Sarah said, allows them to be empowered to get their own care and have agency. But sometimes it's really challenging to get the parents involved if we need them. We obviously never do that without the student's consent. But even with their consent, because of schedules and all of those things, it can be hard to do more holistic work with the family. We are a brief model, but unfortunately that doesn't always work out. And even though students might need a much longer term care, it's often hard to get them into that care. So the wait lists are long. There's just a lack of places that we can refer them to, especially depending on location and language and insurance and all of those barriers. And then logistically, it can be hard for them to get transportation to other places. Or as Sarah also mentioned, if a student misses for, a million different reasons, they may not be able to reschedule. Whereas with us, we're quite flexible about those things. So it's challenging that we see they might need more care, but we can't always get it. And then HIPAA and FERPA, Meg is going to go into more, but these are differing types of confidentiality between medical systems and school systems. And another challenge is that sometimes we get referred, often we have students referred from teachers, and the teachers or the administrators might have very different priorities and hopes for what the students get out of the therapy than the students themselves do. And we can have a lot of pressure of like, they're not doing better in school or they're not getting better, where, from the student's perspective, doing better in school might not be their priority right now with everything they have going on. And then lastly, we work within multiple structures and systems, all with their own challenges. So I think this comes up sometimes, like we're really trying to promote healing-centered or trauma-informed care. And sometimes because of the systems that are schools and medical, they're not always putting that first. And so we really try to shift the culture and the climate, but it can be challenging to feel the difference between those systems, and then also just the different pressures and challenges in each of those systems.
So I'm just going to speak briefly to these two laws. So probably, I'm assuming most of you are familiar with HIPAA. I can't see your faces, but I'm imagining most of you are familiar with HIPAA, which is the law that governs confidentiality in medical settings. FERPA is a corresponding law relating to educational settings. It stands for the Family Educational Rights and Privacy Act. And this law relates to the ways that schools need to keep students' information confidential. So there are a lot of dilemmas, and we could talk about this for hours, but I will keep it brief for now, just to say that first of all, in schools, although FERPA in theory guards students' educational confidentiality, the reality of schools is that schools are places where there is a lot of gossip, there's a lot of conversation, there's a lot of informal talking. Many people who work in schools actually don't know very much about FERPA and are not well informed about the ways that they are supposed to be protecting students' confidentiality. So on top of that, the fact that we have HIPAA, which is a different and slightly stricter set of guidelines, can cause problems for us in working together with the school. So a couple of examples, one of the biggest ones has to do with settings where there's an expectation of information sharing. So as I said, often in schools, it's very common that teachers or sometimes guidance counselors or other school staff may be talking about a student in a setting that's not private, or may share information with each other about a student. So if a school refers a student to us, they may expect that we can share back, that much information, or that we can tell them this much about the student. We all participate in our school's coordination of services teams, COST, where students are referred for counseling or other support services. And the one at my school is very large. Sometimes there will be multiple people discussing the student around a table. So one person might say, well, here's an interaction that I had with a student the other day. Oh, here's something that I know about what's going on in the family. Oh, I heard this thing from the student. And, while the intention is to help the student get help, it sometimes means that we're in a position of, being asked to provide, or being expected to provide, more information than we are legally able to provide, because we have to protect the student's privacy. Another example might be students that are in special education services and have an individualized education plan, an IEP. And perhaps that student actually doesn't want me to communicate with their special ed case manager. Maybe they don't have a great relationship with that person, or maybe they don't want that person to know they've been coming to the clinic to receive reproductive health services, for example. And so I'm in a position of trying to figure out how to best support this student to respect their wishes, but also sometimes be able to communicate with other people in their life that can help them with their goals. And then the other major situation that comes up often is around risk assessment or crisis. So an example would be that I may have to initiate a psychiatric hospitalization for a student. The ambulance may come to the clinic to get the student. The school is not aware. We can inform them that the student is leaving, but we can't inform them why. We can't give them any information about the hospitalization. I'm sure you can imagine that this is very frustrating for the school, school staff wanting to know. And also sometimes it's hard because there are situations where it would be really beneficial for the school to know, so that when the student comes back from hospitalization, someone checks in with them and helps them transition back into their classes. So one of the ways that we've typically addressed this is we've made it part of our procedure that if a student has to be hospitalized, that we always ask the parent for permission to share this information with the school. So if they don't give it, we still can't share it. But at least, we're letting the parent know why that might be helpful and kind of giving them the choice about that. So, generally I'd say our solution to these dilemmas primarily has to do with transparency. So just being really clear with school staff and with students about how confidentiality works and what we can and can't share, and then asking for consent. So being able to anticipate or expect the situations where we might need to or want to share information, and being able to ask for consent so that we can work together to best help the student.
There's a question in the chat, and I think it probably makes sense for us to answer it now. So it says, will you speak to the business model and sustainability? I live in a state that doesn't have a reimbursement mechanism for integrated care in schools, but we have incredible needs in our schools, and our kids aren't accessing community services until they're in crisis. How do we create a sustainable model? Either of you want to answer that one?
I mean, I can briefly say all of us are in the more of the direct service, so we're not necessarily the ones who are finding the funding. But a lot of our services are not billable, even in California, because we try and take away any barrier to care. All of the services that happen in a health center are free, which means that if it's not covered by insurance, it's not covered. And so our agency has a planning department that writes for a lot of grants and a lot of does a lot of development specifically around school-based health, so that we can have these things funded. I'm not sure if that totally answers the question, but I do think that is something that we have to consider, is how do we continue to make this sustainable. And it is an issue that we see in California, though. In California, there is a lot of funding available for school-based health. I don't know if either of you have more.
Yeah, I will just add that the California School-Based Health Alliance is a really great resource, and they often do webinars on this very topic. And actually, I believe they have maybe some resource guides on their website. So although they're specifically focused on California, I imagine that there is some information there that you might be able to use in your state to think about possible funding sources. And I appreciate your point, right? That when kids aren't accessing service until they're in crisis, then they end up in services that are ultimately much more expensive and not cost effective from the standpoint of funders. So I hope that you can find a way to advocate for that.
Yeah, and Julie, I see your question. We're going to get to the pathways in a second. Here we go.
Okay, so how do folks get to us? We were talking about this and came up with these 4 primary ways. The first is self-referrals, either because the youth walks in themselves to request an appointment, or with the support of a friend, family, or teacher. They might come in themselves. Another is through our medical. So we have really strong partnerships with our medical team. And so we get what we call warm handoffs. I believe Meg shared earlier that one of the people that she saw came through from a medical provider when they'd screened for behavioral health. The provider I work with is incredible. She, in addition to doing the formal behavioral health screenings, it does a really good job about checking in on folks' social emotional health when they're in for things like anything. You know, they're there for an injury with sports. She'll ask them about sports. She'll ask them about their stress levels. And so I'm often getting referrals from the provider I work with. Then we get referrals through COSS, which is the Coordination of Services team. Those are referrals that come from educators or school counselors. Oftentimes, they don't have the full picture, but they have a sense that something is going on. It will usually include what they've already tried. It will include whether they've already talked to the student about the referral, or if it's a referral that the student is unaware of, which can provide challenges. And then through screenings, both that we do ourselves. And so some of us will also do population-wide screenings in classrooms for things like behavioral health. So for trauma screenings, or this year I did a brief trauma screening, and then I also did brief anxiety and depression screenings in 6th grade classrooms as we were returning from remote to in-person learning. The school district actually had requested that every student be asked about mental health. And so that was one of the ways that I supported the school in doing that, is through screenings. And so a lot of the folks that I'm seeing this year came through those screenings. So this is my student that this is our second and last case presentation. And then after this, we will have a couple of more slides and we're going to get to the full question and answers. And so looking at the time, let's save all the Q&A for the end, Michelle. So this is Andres. Andres was referred to me when he was 12 years old in 6th grade. He's an Afro-Latino queer trans boy. When he was referred to me, he was referred because the school had seen him with self-injury wounds on his arm and were concerned about depression. At that time, he was not out as trans, and so the school was using a different name and pronouns for him. And so I worked with him for that year, primarily on depression. And then we closed for the pandemic. And when that happened, he was experiencing an increase in conflict at home, and eventually disclosed that there was a lot of abuse happening at home. And so he was eventually moved in with a relative in foster care. And during that time, he also came out as trans. So this is a young person who I could talk all day about his self-reflective capacity, his resilience, his joy, just his like determination to know deeply who he is, and also for others to respect that about him. And so in the course of a year, he was moved in with a relative. He came out as trans, both to myself and also to the full school community. And part of his goals in his gender transition were medical related. And so in the beginning, our work before he'd come out as trans had really been focused on DBT related skills, so distress tolerance skills, skills related to like harm reduction with self-injury. And then once he came out as trans, it provided a lot more context and clarity to the depression. A lot of the depression was really linked to his experiences of gender dysphoria, being misgendered, being called a name that did not feel true to who he was. And he could really name that for himself. And so he requested support getting having a medical transition through hormone replacement therapy. And so I was able to, because we have a gender clinic through La Clinica, and also a primary care physician on site, I was able to refer him to the gender clinic. And he now gets all of his gender treatment primarily through the school health center. So initially, they ran labs and things like that. And once he initiated the treatment, he was able to receive it in the school. And so that's been really, really useful for him. It's allowed him to not miss any of his treatment. It's allowed him to get care discreetly. And it's also in his being able to access the care that he wanted medically, it's really reduced his depression. And we know that, right, about trans folks, when they're able to access care that's gender affirming, when they're able to do the things that allow them to feel at home in their bodies, that we see depression and other mental health symptoms reducing. And so that's happened for him. That's also largely because he's had a really supportive school community. He's found friends and social acceptance and adults who care for him. And so in all of that, he's really had a reduced need to see me. And he mostly just checked in with our provider for his gender affirming care there. There's also been, some work I've done around family psychoeducation when he first came out, for the relative that he's in care with, really supporting her in building the skills that she needed to be an affirming parent, an affirming home, which she wanted to be, but didn't always have the language and skills that felt that way to the young person. So I did a lot of work with the family as well. And we can move on. And if you have questions about this particular case, you can save them till the end of the Q&A.
Great. So we are going to do one more mindful moment. We're going to do mindful movement this time, another example of things we do with our students and to just give you all a break. So we're going to just do a quick one. You can start again with your feet on the floor. Close your eyes if you feel comfortable. Imagine your feet touching the foundation below you, the dirt below that, and the tree roots below that. Stretch your head and your back and your neck up high. Imagine you're like a giraffe reaching for a tree. And take a couple deep breaths, just noticing any tension, thoughts, or feelings. Then we're just going to breathe in and raise our arms above our heads. So inhale, pause, reach up high, and exhale as you bring your arms down. We'll do that 2 more times. Inhale, pause, and exhale. One more. Inhale, reach up, pause, and exhale. And then you can move your hips around a little in your chair, back and forth. Taking a couple more deep breaths and noticing if you feel any different after a moment of mindful movement. And when you're ready, you can come on back.
Okay, so we're just going to speak briefly to some of the modalities that we use in this setting, and we all draw from a lot of different practices. So each of us is just going to speak briefly about some of our favorites. So what Michelle just did was a lovely example of one of my favorite things, which is both mindfulness and also anything that includes the mind and the body. My training is in somatic experiencing, and I love both teaching youth about trauma in the body so that they can learn about how healing also comes from the body. And because our work is short term, and I know there was a question in the chat about typical treatment timeline, which we can talk about more later, but because our work is short term, I really love anything we're able to do that's very present focused. So, we may not be able to have an hour every week all year long, but in this time we have together, if I can give them an experience that they're going to take with them, it feels like a really good use of our time. So a student just shared with me today that actually the exercise that Michelle just did, that he went back to school and taught it to his teacher and did this together with his teacher, and that he's been doing it on his own, and it really helped with his stress. I've had students sometimes tell me that they like being able to take exercises or practices and share them with their friends or with other people. So to me, these are activities that are really empowering, that support youth agency, and are also really cross-culturally comfortable for students from a range of different cultures and backgrounds. And I also really enjoy doing solution-focused work with youth. I'm imagining that most of you are kind of familiar with this approach. It is also a really agency-oriented, in the sense of giving youth empowerment and agency approach that really allows the young person to be the expert. So as an example, today a young person was telling me about a conversation they had with a parent that actually went better than previous conversations have usually gone. So I was able to ask them, tell me a little bit about what you did in this conversation that was different. And so instead of me saying, oh, you did a really good job with this, this, and that, they're able to then share with me, they're able to identify their own strengths and their own abilities and things that they have within themselves. I'll pass it over to you, Michelle.
Thank you. Yeah, one of my favorites is narrative therapy, which actually Meg just kind of set up really well with solution focus. It's a good segue. So the premise behind narrative therapy is that problems are problems and people are not problems. So it really works to externalize problems outside of people and help people to see both the impacts that the problem have on them, but also the ways that they impact or have agency over the problem. And I really like narrative because it brings in a lot of discourses, societal discourses, and systemic impacts, and looks at power also in the therapeutic relationship. So helping students see what kind of messages they're getting from media or, their peers or their parents that are impacting them, and then sort of what they want to how they want to understand that. So an easy example is talking about body image and kind of helping people to see where they're getting these ideas of how their body should be, and connecting it to bigger things like patriarchy and white supremacy, and then helping them to see sort of how they see their body and how they want to understand it and have agency over that message and really not internalize it as something that's wrong with them. I also like to use psychoeducation a lot, especially around trauma. As Meg mentioned in her case study, so often these students are having reactions, or some people call them symptoms, that make them feel like something's wrong with them. And so trying to help them understand how their body is reacting absolutely normally and even as a coping skill or a protective factor in a trauma, and helping them to understand and then therefore be able to shift if they really need to use that coping skill or not anymore. So again, to not pathologize whatever they're experiencing. Pass to you, Sarah.
Yeah. And you know, it's interesting. I think all of us are drawn to embodied practices. And so for myself, I use a lot of DBT skills, because it supports folks in tuning in with what's happening internally, giving them strategies and skills so that they can calm the intensity of the emotions that they're feeling in order to respond to oftentimes the very distressing things that are happening around them. And so having skills around distress tolerance, around emotion regulation, around interpersonal effectiveness really can support young people. Particularly, you know, I work with a lot of middle school students. Emotion dysregulation is kind of the norm in middle school. And so when you add in trauma and injustice, things feel big already, and then they feel so much bigger. And so being able to have some ability to identify where they're feeling that emotion, what is that emotion, and then what can I do with it so that I can respond to it in a way that will feel both soothing to me, and also if there's a problem that can be solved, figuring that out is helpful. I also really love doing groups with young folks. I think that groups are a great way of supporting folks and connecting to others who have similar experiences to them. One of the main things I hear in my office is how lonely people feel, how isolated they feel, how it might feel like they're the only one going through the thing they're going through. And so being able to facilitate groups is really one of the things I love. I've run trauma groups, and this year I've run a couple of grief groups. And so especially in the grief group, I've just seen the ways that group dynamics can really support healing in a way that it would just take a lot longer in individual sessions, and may never be exactly the same as a group experience where you're getting to talk to other folks. And I get a lot of feedback from the youth that, you know, I don't get to share about my, you know, I ran a parental loss group. And so like someone said, no one ever talks to me about my mom. Like other kids don't know what to say to me. And it was so nice to like have people who actually wanted to hear stories about my mom. And so those are things that I do often, are the groups. And there's other things we do as well, but those are some of them.
So we don't have a ton more time, but we have a little bit more time for questions. There is one question about typical treatment timelines. I don't know, Sarah or Meg, if you want to answer that. And then feel free to put any other questions in the chat and we'll get to as many as we can.
So our work is intended to be short-term. So generally that means somewhere between 1 and 10 sessions over the course of a school year. Most commonly, we meet with students every 2 weeks as sort of a matter of course, and with the flexibility to meet more often if there's need, or less often when things are going better. In practice, what that looks like can vary a lot. I've had students that I have worked with over the course of 2, 3, 4 years, not necessarily seeing them constantly that whole time, but you know, sort of coming in and out of treatment as needed. So maybe they come in for one episode 1 year, then things are going better. And then in a year or two, they might come back when they feel that they need to again. So one of the nice things for me about school-based IBH is really being able to allow for some of that in and out, which I think is really great for teenagers and maybe all humans, having the opportunity to decide when you want the service and when you're feeling good and you don't need it.
Here's another question. How do you see, or do you see, prevention happening in the school-based IBH system?
Yeah, I think we see a lot of prevention happening. Some of that is through more of our population-based work, screenings, incorporating mental health into primary care, which is just a part of integrated behavioral health, but especially at school sites. Annually, students who come in for any sort of appointment are asked about mental health. And so it's a way of capturing things. It makes it part of the shared language for students. I find that students start to learn when to ask for when their stress levels are getting high. But also allows us to capture folks who are maybe experiencing really mild anxiety or depression, so that it's not having to get to that crisis point.
Yeah, I would also say that being a part of the coordination of services teams, teachers catch things early. Teachers see these students every day, and so they notice things and will send us referrals. So I think that helps a lot with prevention. And then also, as was mentioned earlier, just like that we're around and people know the clinic's there and they know their friends go. And so there's some comfort in just coming in if they're stressed about something and then often getting connected to care.
Yeah, I wanted to add one more thing to that. I'm noticing I was focused on like individual mental health, but other things that are prevention are the climate and culture work. So, right, we work in an education structure and system that is really traumatizing, just like on its own. And so being a part of changing the culture of a school campus, of naming when we're noticing like, hey, it seems like a lot of the out of class discipline right now is happening with Black boys, and naming that at the COS team meetings is also like prevention work, right? So it's not just individual, it's also about participating in a community culture of like unlearning and undoing these systems.
Yeah, I obviously thank you all. And I obviously asked that because I really appreciated that statement about let's ask every kid about their mental health. And I know that was pandemic oriented, but it brings up, are we doing this regularly? Is that something? And it, like I always think of the dental model, which I know dentists aren't always accessible for many of our kids, but having it be this routine cleaning or checking in. And so really appreciate hearing about the kind of population screenings and things like that. This has been so enlightening. I want to make sure no one else has any questions because we are in our last minute. Well, I don't know. I'll end this and you might not be happy with me, but if you could change anything right now, I know you're working in a very difficult system with lots of structural barriers. Is there something in particular that really gets in the way that you would like to change? And if that's just too vague and broad, I understand, but maybe something to leave, like what is sort of the most pressing issue for you all as you're trying to address mental health needs with the kids?
I saw someone commented lack of service providers in the chat, and I'm going to agree with it. I just was talking today to a parent who's like, I'm calling therapists. I'm trying to find someone. So, I mean, our mental health system in this country is so fragmented and strange based on insurance. It's so hard for people to access care at the time that you most need care is the time that you have least bandwidth to call 500 providers and get a pre-authorization and, all the different things. So I think there's a need for kind of a broader overhaul. And then during the pandemic, because there's been such a surge in mental health needs, and I think in people seeking care. So definitely there's a volume problem and a system problem in terms of access to care, especially to, more on ongoing long-term therapy.
And I shouldn't have left that on a negative note, because we are so grateful for all the work you're doing and sharing it with us. It's 5:01, so I am going to gently say goodbye and many thank yous for your presentation. And for everyone, this will be posted on our website within a week, as well as the PowerPoint. So thank you everyone for coming. Lots of thank yous from the audience. And wishing everyone a good rest of their week.